Okay, I think we'll go ahead and get started. It's a little after the hour. I'm really excited to talk to you today about this topic of maximizing economies of scope and scale for anatomic pathology. We were supposed to have Dr. Esther Rossi today, but she is traveling and has some problems with connectivity. So we are going to be hearing from her on June 13th. So this week, I will do this session in place of her. And this Thursday, we also had a schedule change. Christian Jobian, who's going to talk to us about microbiome, is not available, but he is available on the 20th of June. So we have a free day this Thursday, but we will resume next Tuesday with our regular scheduled people all the way to June 20th, and apologize for those changes to the schedule. But today I'm happy to talk to you about this topic, which is near and dear to my heart, and a recent publication that has been submitted, which I will go through in detail with you. So this is the outline for today. One second, sorry about that. There we go. So first, we're going to talk about institutional types and budget types, and try to stress the concept that context really matters for this aspect of budget planning. You really need to understand what type of institution you're in and how that budget will work in order to determine how you will figure out your budget for your lab and how you can, for example, use the tools that I'm going to describe. I'm then going to talk about patient populations and catchment areas so that you understand how you know your patients. You all probably already know this. This is just putting some terminology on it so that you are aware of how you think about this from a budgeting point of view. Is that Gloria? Let me see if I can mute her. Gloria, I'm going to put you on mute, okay? Okay. All right. Then we'll talk about pathology services, costs and charges, and who sets the prices and what that means. Then talk a little bit about drivers of pathology department budgets, what that is, and show you that consistently it's the same two factors that drive those budgets. And then lastly, I'll do a detailed explanation of budget planning with our interactive form, which has been submitted for publication, and happy to work with individual laboratories to help you use that. And we'll switch to the interactive form and look at that. And then I will show you some data on how that form works. So let's talk first about institutional types. Sorry. Not sure. Gloria, can you mute yourself, please? Hopefully. Okay. So let's talk about institutional types and the implications for budget. So when we think about a private institution, this is an institution that's devoted to revenue generation, right? The goal of a private institution is primarily to generate income. And that may be for the people who run the lab because they own the lab. It may be someone who owns the lab and has someone else run it for them. It may be a corporation. It may be a network of laboratories, for example. But the whole goal is revenue generation. And so in that type of laboratory, all operating expenses must be covered. All operating expenses must be covered by revenue from the performed work. So there's no option for paying for something and not having revenue. In other words, you can't have a budget where your budget of costs, your expenses is $100,000 and your revenue is $95,000. That won't work because there's a negative $5,000 deficit and there's no way to make that up. So in a private institution, which again, we're just using that as a classification, this is a laboratory or a budgeting approach where the revenue is the primary goal. We want to have a positive margin of cash for those who are owning the lab or making money off of the lab. And this is very common in the US. It is definitely common in Africa. You've all seen private laboratories. Not so common in Europe and Canada and Australia, where they have socialized medicine, although there are private institutions. Most of those institutions are public or government-run institutions. Then we have what we call public institution, and the goal of a public institution is service provision. You could also put this into the same category as a nonprofit or a not-for-profit in the US. And here, the operating budget could come directly from the government. The operating budget could be supplemented by revenue from the work that's performed. So you may have the government providing some budget to serve for this organization, and then patients may pay a little bit, not the full amount, but a little bit in order to supplement that, and that covers the cost. And the budget is typically managed annually using annual procurement, or it could be done on the 6-month or the quarterly. When we look at private institutions, their budgets are managed almost daily or weekly, but they can choose to use larger timeframes. Then a third category are academic institutions. And I make this category distinction because these could be public or private, but the academic institutions have research and training as one of their primary goals of what they're doing. They're absolutely doing service provision. They may or may not be doing revenue generation, but as part of what they're doing, they have research and training. And why is that important? Because the operating budget may be supplemented by grant revenue. So you may have, 10 pathologists in a laboratory, 8 of whom all have research grants that have overhead that are providing a significant amount of money to that budget. And so the cost of services could be lower, or they may use those funds to expand other areas, et cetera. But you're not supplementing the budget with just like a directly provided government budget, but rather by overheads from grant revenue. And the overhead in this case may be very high to cover non-clinical work activities. For example, if you look at Harvard in Boston, the Harvard School of Public Health has an overhead rate on an NIH grant of 34%, but the Brigham and Women's Hospital has a rate of 78%. So if you are a faculty member at Harvard and you happen to be at the School of Public Health and at the Brigham, and you apply for an NIH grant, let's say of $100,000, if you apply for that grant through the School of Public Health, the NIH will send you $134,000 because that $34,000 goes to the School of Public Health as, in quotes, overhead. If you applied for that grant through the Brigham and Women's Hospital, you would receive $178,000, and $78,000 would go to the Brigham and Women's Hospital for overhead. And what is that overhead? That's electricity, that's square footage of the building, power, water, janitorial services, food services, air conditioning, all the things that have to happen and be paid for in that space for you to operate there to do your grant. And that 78% or 38% offsets some of the costs of the other things that are happening in the lab. And then you have what are called public-private partnerships, and these have mixed outcomes. This is a combination of public, like government, and private, like revenue generation, with various configurations. And it can be that the revenue is the primary generator, but only a portion of that revenue is for profit, and the most of it goes to actually offset the cost for patients, which is what we see in most public-private partnerships. So there's just examples of institution types and budget types. There are other examples. This is just commonly what we see in Africa and the US, so that's what I wanted to use as the example. Now let's talk about patient populations and catchment areas. So a population is a defined entity. You can't just say, oh, what's the population? You have to say the population of what, right? So the population of Nigeria, right, at some point was 195 million. Now I think it's 231 million, but it doesn't matter what the number is. But you can say the population of a country, for example, Nigeria, the population of a state within that country. So Oyo State, the population may be 5.58 million, or the population of a city like Kaduna may be 1.6 million, right? But that's what we mean by a population, the population of the United States, the population of patients with cancer, the population of Canada, the population of a small island in the Caribbean. So it's just the total number of people that are there. And it's often a legal district, right? When we're talking about a population, we often use a legal district to define it, like Europe or an island, et cetera, et cetera. The patient population, excuse me, is the number of those inhabitants that are using the laboratory for services. So note in our Venn diagram on the left, we have the population, which is that legal district. And then we have this dark blue circle of patient population, many of whom are in that population, but you note that they're not all in that population. We'll talk about that in a second. So this is the patient population, the number of inhabitants using that laboratory for services. And they have other options, right? They can choose other labs. Then we have our catchment area, and this is the geographic region which uses the laboratory for services. So think about this. So the catchment area includes the area, the physical area where the patient population is, as well as where the patient population is. So that catchment area is a subset, or it's a not a legal border, but it's a geographic border that's actually defined by the population that's using the lab. And then we have a third term or fourth term, which is the catchment population. So this is the actual population in the catchment area who could use the laboratory for services, but they may choose not to. And so let me give you a good example of this on the next slide. But so it'll make more sense. But the other thing I want to talk about is that for 1 million people, which is a catchment population, right? So for that area that could use a laboratory in a given physical, or people in that physical location, about 1 million people, there'll be about 5,000 new cancers per million, which will produce about 10,000 new biopsies or tissue samples per year. So keep that in mind when you're thinking about these numbers. So let's look at an example of why these patient population catchment area terms are so specific. So here we see Rwanda, and in Rwanda, you can see that there's the legal border of Rwanda, which it shares with the Democratic Republic of Congo, with Uganda, with Tanzania, and Burundi. And we can define the population of Rwanda as being within that legal border, right? That legal border of what's there. But we look at the laboratory in Butaro, which is in the north, and you can't see it, but it's right next to Lake Barrera. So there's a laboratory in Rwanda that serves the catchment area that are these gray boxes, okay? So these gray circles. These gray circles are where patients come from that use that laboratory, right? So there are patients from the north of Rwanda, as we would expect. There are patients from Uganda and Congo that come over the border to use those labs for services. There are patients in Butare, where the medical school is, who travel up to Butaro to use those services. And then there are patients in Burundi who travel all the way up to Butaro to use those services. So this is just an example of how, when we're trying to plan a laboratory in Butaro and how much volume is there and what that lab should look like, we can't just think about, oh, there's some portion of the population of Rwanda that's there. We have to think about the catchment area of that laboratory and our patient populations. Where do our patients come from and where are they going to? And this becomes really important as you're thinking about, for example, Rwanda as a country, right? There's already a lab in Butare, but they don't have histology. They only have F&A. There are 3 laboratories in Kigali, and those 3 laboratories serve all the rest of the country that you see here, although there are definitely patients from Kigali that go to Butaro. So again, not to make this, to oversimplify this, it's just trying to illustrate for you that when you're trying to design a laboratory and you're thinking about volume, which we'll talk about in a little bit, that volume is not necessarily coming from just the patients that are around you directly. They could be patients from another country, they could be patients by referral, et cetera, and you need to think about that, not from a point of view of total volume planning for the lab, but really from a point of view of marketing, right? Who do we need to talk to at the primary care level to get them to send us biopsies to our laboratory, right? If you are in Butaro, you need to talk to people in Uganda, in Congo, in Burundi, in Butare, if you want to maintain this current patient population and catchment area. But maybe you actually want to get more patients from Rwanda, so then you want to go talk in Bayomba or Gisenyi or Gitarama or Nyanza, because they aren't sending you samples and you want them to send you samples to increase your volume, okay? All right, so let's talk about pathology. Let me just make sure I didn't skip. So yeah, let's talk about pathology services costs, and charges, right? So I have a better slide of the services in just a second, but in general, when we think about pathology services, we think about the simplest being fine needle aspiration, which you're all familiar with, where you use a needle, you stick it in a lump or a bump, you take out some material, you smear it on a slide. And this has a very low cost of supplies and reagents. It has a very rapid turnaround time. It does require a cytopathologist or a cytologist who has advanced training. So the personnel is not inexpensive for this. You do have to have a highly qualified personnel. And you also only receive limited information, and you have a limited reach of patient lesions unless you have radiology, right? So if you're just there with a patient with the fine needle for the needle, you know what you can get to, right? You can get to anything in their arms or legs that you can feel. You can get anything in their breast that they can palpate. You might be able to get things in their head and neck that you can palpate, but you're probably not going to mess around with the abdomen too much without an ultrasound. And you may not want to do anything in the lung or the liver, the kidneys, et cetera, without maybe even CT guided fine needle aspiration, right? So it's a little bit limited in what you can get to, but if you can get to it, you get really good information for that patient. The next is a small tissue biopsy. So this is one step up from fine needle aspiration, where there's a medium cost of supplies and reagents. You do need things like scalpels and formalin containers, et cetera, to take that piece of tissue. It's a shorter turnaround time. It's not rapid, but it can be a pretty short turnaround time. But it's complete information, but again, limited reach for some patients, right? So you can easily take a small tissue biopsy of a lymph node in the neck, or a lymph node in the groin, or maybe something on the skin or something in the breast. But it's hard to take a small tissue biopsy of the liver without ultrasound or some other imaging system in order to be able to take that sample safely for that patient. So it can be a little limited. All right, what's this question? Okay. So to answer the question that just came in the Q&A, yes, if you are here registered for the course or you watch it online, you can receive a certificate from the course directors for being part of the course. Okay. Next, we have our surgical resection or complete biopsy, which you're all familiar with. This is the highest cost of supplies and reagents. The turnaround time should be less than 5 days. The average is about 3 days, and it does give you complete information. So this is a mastectomy, a lung resection, a colon resection, a kidney resection, a large skin resection, right? It takes you time to process it. It's a lot of intense work for the pathologist and the technical staff and the lab staff, et cetera, but it gives you the most information, right? And you can pretty much reach anywhere if you have a surgeon that can open a patient to get a sample. And then the last we don't want to forget about is an autopsy. Autopsies tend to be quite costly because of the PPE and the amount of work that's done, the personnel, et cetera. The turnaround time is sort of irrelevant, but it's sort of the final chapter for a patient's life. But often the challenge with autopsies is not compensated for, certainly not in the US system. And in Africa, primarily autopsies are done in the forensic setting or in the medical legal setting with the police. And so medical autopsies are fairly uncommon unless there are research studies, which I'm sure many of you are participating in research studies that use autopsy. So when we think about those are the services. So when we think about the costs, what we mean by, and this is a very specific term, what we mean by cost is what the laboratory pays for its operations, right? So this is literally the physical discharge of money in order to have those services. So you buy reagents from a vendor, you buy supplies from a vendor, you purchase equipment and install it in the lab. You have to pay someone to come in and do service and maintenance on that equipment. You have overhead, which I mentioned before. You're in someone's space with electricity, water, and internet. You either pay for that electricity and water and internet directly, or you just pay some overhead fee, and then the overall hospital or organization pays for that electricity, water, and internet for you. And then you have your personnel, both your technical and your professional, who need to be paid for their services. And these are all costs, right? Those are things you have to pay for in order to have a lab. These can't be free, right? You can't run a lab if everything is donated, because then where do you get the next donation? You have to spend a lot of time trying to find donations. You need to have a budget to buy these things in order to supply them to the services of the lab. So there is economy of scale in pathology services. The cost of reagents and supplies per sample goes down with the increased volume of the lab. And here's a great way to think about this. If you have an H&E staining setup that works for 10 days, right? It's valid for 10 days, and then you have to change it. You can stain 1 slide per day, or you can stain 300 slides per day. Right? If you stain 1 slides per day, that was obviously very expensive to have that H&E setup. If you stained 300 slides per day, then that cost is much lower per slide because you're running so many through. Okay, so that's an example of economy of scale, right? And then there's economy of scope, right? So you use tissue microtomy for histology, but you also use it for special stains, and you also use it for immunohistochemistry. So you don't need a microtomy system for special stains and for immunohistochemistry separately. You can use the same microtome, the same techniques to produce an unstained slide, and that does economy of scope. You use the same tool for multiple things, which saves you money. Okay. Now, here's a thought experiment that we can do around costs, okay? Let's assume that the laboratory receives 1 sample per year. That sounds ludicrous, but just work with me here. We receive 1 sample per year. That laboratory has to have sufficient supplies and reagents to process that 1 sample, and staffing to gross, process, and read that 1 sample. And all costs are only divided by 1, only the 1 sample. So the cost per sample is enormous, right? Because you've got to have a laboratory professional, a pathologist, an administrative person, all of the physical equipment, all the reagents and supplies. And even though you're only doing 1 run to read that 1 slide, it's going to cost a lot to do that. Now assume the laboratory receives 500 samples, 5,000 samples, or 50,000 samples per year. So our economies of scale come into play. That cost per sample goes way down, right? Because all of those things we had to buy, the large things, the fact that the pathologist is already there, the technician is already there for the full year, that now all gets divided by each sample that we add to the mix. There are costs per sample that we have to think about, so it's not pure math, but the take home is you're getting your cost to a low point, right? Where the cost per sample should, what we call plateau, and then make the lab fiscally stable. And where the volume requires additional resources, like more equipment, more personnel, that's the threshold of the scale benefit, right? And I will show you what that means a little bit later. Now let's talk about charges. Okay, we talked about costs. Let's talk about charges. So what are charges? This is what the laboratory charges the external world for their services. Okay, so a nonprofit or a government laboratory may just charge very close to the actual cost. So they may add up what they spend for supplies and reagents, what they spend for personnel, what they spend on overhead, and then just divide that by the average number of samples they have per year, and then say to the external payer, oh, you have to pay me $25 because that's what it costs me to deliver this, right? In a private laboratory, which as we said is revenue driven, they're going to charge a margin, and that's their profit. So they may say it costs us $25 to deliver that service, but we want to make a profit of 50%. So we're going to charge $37.50 so that we make $12.50 off every $25 that we spend. Or maybe they say we want a margin of 100%. So they're going to charge $50 for something that costs them 25, and they're going to make 100% margin on that. Now, in most places, in diagnostics, which is what we're talking about, the margin for most companies that produce diagnostic services, like, so for example, the manufacturer of a histology equipment or the manufacturer of reagents for histology, their margin is generally about 2 to 3%. And that's not because they're only charging 2 to 3% more of what it costs. It's because they have an enormous number of overhead costs that eat into their profit margin. So it may cost them, $10 to produce a gallon of formalin, and they may sell that gallon of formalin for $50. And you're like, oh, they made $40 off that $10 investment. But they now need to spend $37 additional dollars to cover all the overhead for their company, including shipping, safety, biohazard, disposal, insurance for everybody, et cetera, et cetera. So their margins tend to be pretty low. And you can compare that with pharmaceutical companies, which have margins of 25%. And that's because the charges for their medications are very high relative to what it costs to make them. And so they're in just a very, and their physical overhead is much less. They aren't having to produce $20,000 pieces of equipment. They're just producing individual pills, which can be shipped in small packages, et cetera, et cetera. So pharma tends to have higher revenues than diagnostics. Right, so back to the point. Assissa, you keep raising your hand. Please put your questions in the Q&A, okay? All right, so different payers may pay different prices, and this is an important concept, right? Because we're talking about charges now. So government subsidized payments, if the government's going to pay for service, they may do that at cost. So you may have to tell them what your costs are, and they will just reimburse you basically for what you spend. Private insurance may pay twice what it costs you. So you may say, okay, it costs us $45, and private insurance will say, okay, we're going to reimburse you $90 because that's just our reimbursement rate. For out of pocket for patients, you could be at 1.5, 0.5, et cetera. Okay. You guys, please don't raise your hands. We're during the webinar, just ask your questions in the Q&A, and that would be great. Okay. So out of pocket may be 1.5, 0.5, depending on what you decide for your local environment. You may not want to charge too much for your patients, or maybe you have tiered pricing so that patients that are wealthy pay more than patients that are impoverished, et cetera, et cetera. And then a grant, you could get a grant that actually pays 3 times the cost, right? And that's because of the overhead, et cetera, that they're doing. And then, as I said, impoverished patients may not pay for services at all. And I'll show you in the model how that can be very effective or effectively done. So linking the revenue, this is very important, linking the revenue from charges to the operational budget of the laboratory is a key component of successfully managing the laboratory, right? What that means is if we are generating if we understand all of our costs in the lab, and then we generate charges for people to pay us, and we don't collect that money directly, that money isn't coming back into the lab, it becomes very, very difficult to manage that lab successfully, right? And I'm sure you're all familiar with this. So when finances are disconnected from operations, inefficiency, waste, lack of motivation, misappropriation, confusion, and dissension can occur, right? So if you're the lab and you are sending out charges, and the patients are paying those charges over at the hospital, and the hospital is keeping that money and not giving the money back to the lab, or not talking to the lab about how much it's collecting, it causes problems, right? And that's not an Africa problem. It happens in Africa, absolutely, all the time, but it happens in the US as well. There are plenty of labs in the US that bill everything out, they do all their work, and at the end of the day, the hospital just comes back to them at the end of the year and said, oh, here's your operating budget. They don't say, here's how much you made, this is the revenue that you generated. They just say, here's the amount we're giving you to run the lab. And so you're disconnected from how much you actually made. And it's very empowering to have control of your own budget. And so if you can do it, it's very important. So how do we build a budget? So this is a really simple concept. It's actually a standard business concept. So to build a proper budget, the first thing you do is project revenues for the year, right? So how do you project revenues? Well, how many samples do we think we're going to receive? Are we going to receive more than last year? How many samples will be paid for by each payer? Now, remember, a payer could be the government paying for all of it at once. It could be 3 different kinds of insurance paying it at 3 different levels. It could be individual patients paying for their own services. But whatever that is, you want to say, how many of those samples are going to be paid for, and what does that look like? If the revenues are lower than you would hope, how are you going to recruit more samples to the lab? Why is that important? Well, if you need to recruit more samples, that's going to be marketing, and you're going to have to pay something to market, right? You're going to have staff go talk to people, or you're going to have to spend some time doing something, or maybe you put up a poster or you put up a billboard, but you're going to spend money to get more people in. So you can't just say, well, our revenues are low, we need to recruit more samples. You actually have to do something to recruit those additional samples. If your revenues are high, How are you going to invest to improve the laboratory, right? Do you want to add new services? Do you want to add new staff? Do you want to open another lab in another location so you can decrease turnaround time? Like, you have to decide what you do when you do that. And you can include grants, government subsidies, donations, and contract work in your revenues. It's totally fine to do that, but you want to total all of your revenues. You want to know exactly how much you're expecting to come into the laboratory for the next year. The second thing you do is tally your expenses to provide those services based on actual costs. So now you're going to look at actual pricing for your reagents, your supplies, your personnel, and say, okay, I said I'm going to do 8,000 samples in the lab this year. What would it cost me to provide 8,000 samples, right? And then the third step is to balance that budget. So if your margin is set to zero because you're a government lab or a not-for-profit lab or a service-oriented lab, then you want to have the revenue equal your expenses, right? That makes sense. If you're a for-profit laboratory or a public-private partnership, you want your margin to be more. You want it to be greater than zero. You want your revenue to be higher than your expenses, okay? But in no example, in no case ever, is it okay for your margin to be less than zero, right? So if you're looking at your budget and saying, okay, our revenues for the year are $100,000 and our expenses for the year are $120,000, that's a no. You can't, that's not acceptable. You have to have a margin of zero or a positive number. If your margin is negative, then you're not in a sustainable situation, and you have to determine, how are we going to do that? Either, and how can you do that? There's lots of different ways. You can find less expensive reagents and supplies. You can figure out a different way to pay for your staff, including grants or contract work, subsidizing them with other projects, et cetera. You can seek donations to meet that gap, and then create a sustainability plan for how you're going to meet that gap going forward. Et cetera, et cetera. So it's really important that you understand that as you're creating a budget for a laboratory, and this could be someone at the Ministry of Health working on that budget with you, it could be the pathologists themselves, whoever's doing it, it's not acceptable for the margin to be less than zero. It has to be zero or positive. All right, so let's just look at these. You all know this. I just want to show you an interesting range that you can see these cost by services for pathology. So standard pathology, you're all familiar with, histology, making H&E slides, reviewing them at the microscope. Now, the initial setup for a laboratory, if you have an empty room and you have nothing, can be as low as 150,000 US dollars and as high as $500,000. And the difference between those is whether you're in a low-income country or high-income country, right? The cost of equipment is just much lower depending on where you are. Interestingly, however, to maintain that laboratory with reagents and supplies, the pricing doesn't scale the same way. It's about $274,000 for a low-income country and about $1 million for a high-income country, depending on the volume. And the interesting thing about standard pathology is that you can diagnose any cancer except leukemia, right? And that includes, by the way, immunohistochemistry. So you can diagnose pretty much everything except leukemia. And so standard pathology is a good investment because you divide the costs that we have here by basically every patient that comes in your lab for service is going to be contributing towards this operation of this lab. The next group is cytology, much lower initial costs. These initial costs are really related to ultrasound and all the tools that you need. The ongoing costs are pretty low depending on your volume. But again, as we said, you're limited by site, and we can't diagnose leukemia alone. We can't diagnose leukemia with only cytology. We need to have a flow cytometry. Our next service is flow cytometry. This can have a low initial cost if you have a rental reagent lease agreement, but it can have a higher cost if you have to buy the equipment. And then the ongoing cost is not unreasonable depending on the number of patients. And this is great for leukemias and lymphomas. And then there are some other non-oncological uses of flow cytometry. And then the last group is molecular testing. Initially, this can be fairly inexpensive for point of care tests like the Gene Expert, or a little bit more expensive if you're going to go to sequencer. And then the ongoing costs are quite high, right? These are low cost of equipment, high cost per patient because of the reagents needed, as well as the informatics work in order to do it. But keep in mind that this is really limited to a handful of diagnoses. You can't diagnose every tumor with a molecular test. There just isn't that repertoire of tests out there. But what you can do with molecular much more frequently than you can with standard histology is do a specific test to equal a specific treatment. So in pathology, when we look at the H&E, we can make a diagnosis and a patient can be recommended for a treatment guideline. And then we can also do things like ER or HER2, where that means the patient's going to get that's a specific test for them to get a specific treatment. But the vast majority of the testing we do in standard pathology is not, it's just giving a diagnosis and then we're going to treat on that. On the molecular side, we're going to do a specific test like a KRAS or an EGFR mutation, and that's going to dictate a specific treatment for a patient. And so you can't just do molecular testing in a vacuum, right? You really need standard histology in order for you to have molecular testing that makes sense for your patient population. So let's go to this AP budgeting tool that we've created. And I'm going to give me just 1 second to switch to that. Give me just a second. And, oh, sorry. Oh, all right. Okay, so hopefully you can all see this. So this is the AP budgeting tool. Let me go first to the instructions page. So this is a Google Doc that we can share with groups that want to work on a budget or work through their budget or understand their own budget. And what I want to show you on this first tab is that it has a very detailed explanation of every single entry category for this budget. Now, it's not complicated. It's very simple and straightforward to use, but we just wanted to make sure that you had a complete explanation of how to use each aspect of the worksheet. So it's quite detailed there. So now this is the main page of the working overall budget. You can see it says AP laboratory budget. And there are all the green boxes. You can see all the light green boxes. All the light green boxes are numbers that you need to provide. And you have those numbers. You just have to figure them out for your laboratory. Okay, so the most important number is the number of samples per year. You can see here we have it set to 10,000, and that's cases. That's not blocks. That's not biopsies. That's not individual samples. That's cases. So case number 1 is a case which may be a mastectomy with 12 blocks. Case number 2 is a biopsy, which may only have 1 block, right? So this is cases. You could also think of it as patients, even though a patient may have multiple cases. And then and that's the first number, which is quite important. Then we have some other tools that we want to look at. So the first is overhead. So here we designate, is this overhead a flat fee or is the overhead a percentage? And you can put either a % sign or you can put 2 $ signs. And whichever one you put, you're going to come down here. This is why these are orange. You pick only one. You either put a flat fee in your $ one, or you put a percentage in your overhead. And so here I've just put an overhead of 10% just to show how the model works. The next area that you go to are the budget tools, right? So how many days or runs are you going to do? So let's take, for example, a standard year, which assumes about 4 weeks of not operating if you need to because of is that right? Yeah, not operating because of, say, holidays or close downs or annual close down, whatever. So 48 weeks, 5 days a week, that's 240 days, right? So let's assume that 240 days is the number of days in the year that you run your pathology lab. And let's assume you do 1 run per day with your processor. So you've got 240 days and 240 runs, okay? You can also use this model for a month, right? So you could just put, and let's say you're open every day. So you could put 30 days, and then you would put either 30 runs, or maybe you run the equipment twice a day. You could put 60 runs, right? So either way, so you can use the tool for any period. It's currently set up for a year in what we're looking at, but you can use it for any period if you need to. So that working days and runs is very important because it's how many times you run your instrument, which has a capacity, and I'll show you that in a second. The next two numbers are estimates, right? How many cases need special stains and how many cases need IHC? We're using a default here of 25% and 35%. And what that's saying is that of the 10,000 cases we have come in, about 3,500 of them we're going to need to use immunohistochemistry, okay? All right, and then this green box is the average number of blocks per case. We're using 3 because if you do the math in most institutions, that's about the number you get, but you can actually calculate this number. You look at 2 months of time in your lab, how many blocks you had per case, the total number of cases, divide one by the other, and then you'll have an exact number. And you could do 2.6, or you can just round it to 3. It doesn't really matter. The take home is you just want to have a number that is close to the blocks that you have. And then the last block in the budgeting tool is the small biopsies, okay? So if you are primarily an academic lab that's doing all the major surgeries for everybody around you, like a tertiary care center, maybe you don't get a lot of small biopsies. Maybe you only get colons and lungs and breasts and legs and large samples. And that's the bulk of the work that you do. And so your percentage of small biopsies is small. But if you are a typical lab, you may get half the things you get are small biopsies and the other half are largest. And then you could be in a situation where you only take biopsies, right? You only take in small biopsies because you're a regional lab, et cetera. And in that case, the number will be 100%. And why is that important? Because if it's a small biopsy, you're not going to use ink, and you may need to supply containers to the hospital. And we'll talk about that in a second. So those are the big ones for the budgeting tools. And then everything else are just your costs, right? So on the processor run worksheet, how much do you pay for formalin, xylene, alcohol, and paraffin? And then you have to do some math. This is where it helps to have someone that's an expert look at this sheet with you. So someone was saying it's a little small. Let me see if I can zoom in a little bit. Let's see. Let's try that. Hopefully that's better. Okay, so you're just going to put in your actual numbers. And again, the way that this particular one is set up is you have a purchase price from your invoice, right? So your invoice says this lab paid $55 for formalin, and then that $55 for formalin is a certain volume in liters, right? So we bought 15 liters of formalin for $55. We bought 60 liters of alcohol for $353. And then, and so we put that information in based on our invoices. And then we have our volume of processor, right? So in this model, what we need to know is how much do you put in the processor when you fill it? And then we'll talk about a little bit later how you make the changes. So a standard processor uses about 3.2 liters of formalin, 3.2 liters of xylene, 6 liters of alcohol, and 2 bags basically of paraffin, right? So we put that information in. Then we have our pricing for our glass slides, our pricing for our hematoxylin and eosin, et cetera, our cover slips, we're going to put all that in. We're going to come over here and look at our grossing supplies, right? We use cassettes, we use gauze, razor blades, ink, and maybe other disposable items that are there. You can put in whatever you need to. Then we have our reusable grossing supplies, like our scalpel handles, rulers, forceps, probes, other reusable items. And then you want to estimate the usable life based on the budget period. So for example, we're saying there's a scalpel handle and it costs me $25, and I'm going to use that for 6 months of this 1 year period. And then that scalpel handle won't be any good anymore and I have to replace it. Now I've used scalpel handles for years. So it's totally, this is just for as an example. So you may put in a usable life of 100 years or whatever you want. But the point is, certain things are going to wear out and you're going to have to replace them. And so this allows you to say, how much does it cost and how often am I going to replace it? Okay. And then we have our special stains. And this is probably the least developed of the worksheet system. But what we're doing here is basically saying, how much does it cost us to set up a special stain? What are all the costs of the reagents? How much volume do I use of that cost? So let's say we spend $50 for a AFB staining kit, and we buy that kit for $50, but we can use 20% of it each time we set it up, right? So we're going to say the volume that we're going to use is about 0.2. We're going to use 20% of what we paid for each time we set it up. And when we set it up, it's going to last for 10 days. And that's going to calculate for you how much special stain you need. Then we have our personal protective equipment. So we're going to use gloves, masks, face shields, pretty much every day. So how much we pay for them, what comes in there, it's going to calculate that for us. How much do we pay for a bag of formalin, and how many blocks can we get out of a bag? Again, these are just estimates that you're going to make. Now, theirs is an interesting section, immunohistochemistry. Notice that it's just a flat number, and I'm going to talk about that in a little bit later. But the key here is that we're gonna subsidize our immunohistochemistry over all of our patients. Okay, so we'll come back to that in a second. So let's go back over here and look at a couple more things. Equipment and other. So preventative maintenance, we're gonna have to spend money to keep our equipment running. External preventative maintenance, maybe we have to pay someone once or twice a year to come in and do some work, and then other supportive keep. And then we have our staff. Right now, notice that the numbers 1, 2, 2, 1, etc. Those you can't change. You don't get to say how many staff you have when you're using this budget sheet. All you get to do is say what you pay them, right? So you put in the salary for the grossing staff and the salary for the pathology staff, etc. This spreadsheet is done in US dollars. You can obviously do it in your own local currency. Anywhere you see a dollar sign, you're just going to put in your own local currency, and you can actually just know to convert it if you need to. So then once we have all that in, we only need to do two more things. The first is we need to put the percentage of pro bono patients. Now, let's say you're in a government laboratory and no patients in your lab pay for services. The services are totally free, and you want to do that. What you would put for a percentage of pro bono patients is 0. Don't put 100% because that's going to confuse the model. You put 0 and you just assume that no one is paying. Okay, that's how that will work. And then you have your margin. So if you're a private lab and you have a margin of 5%, you put in 5%. If you're a government lab and you don't really need to have a margin, you can put in 0%. And then two things are going to be and then there's one other thing you put in, which is the list of price of services. So now what's this model doing? This model is generating this number, right? That 40.52, that's $40.52. What does that $40.52 mean? What it means is that for your laboratory to receive 10,000 samples, 10,000 patient cases in a year, process them, read them, perform special stains, perform immunohistochemistry, do everything you need to do. For each of those cases, you need to bring in $40.52, okay? With the exception of this 5% of pro bono patients. They're not paying. So for everyone who's paying, whether it be from government budget, grant money, donations, patients paying out of pocket, wherever the source is, you need to collect $40.52 per case that comes in, okay? That doesn't mean you need to collect $40.52 from the patient. It means that you as a laboratory need to collect $40.52, okay? Now, let's go over to another page of expenses and revenue summary. Now, what this does is takes everything from that first page and sums it for you for the year, right? So our revenue, including, notice it says including external bulk funds, our revenue is $384,909. That is that $40.52 times all those patients on the first page that we're paying, right? Not the pro bono patients. Then we have our costs, which are $366,000, and we have our margin, right? And that's our pre-tax margin, because you have to pay taxes on income. And notice that we have a margin of $18,329, right? Because we wanted to have a margin. We said we were going to do that. And then we have something called total excess revenue. So let me come back over here for 1 second and show you this. So let's say we have 0 pro bono patients, okay? That's going to go down. And let's say we're a private laboratory and we want to have this 5% margin. So now we're going to set our price, because we're trying to be competitive, at $38.49. So what we've said is we're not doing anything for free. We are going to have a 5% margin, and that's $38.49, and we're going to charge $38.49. So when we go to our expenses and revenue summary, now what you see is that our revenue's there, our margin is there, and the total excess revenue goes basically to zero. $9 is just an error in the fractional pennies of the system, which is fine. And so our total excess margin equals our margin, right? So we're where we want it to be with that. But notice that, let's say another lab opens up and they're charging $42 for their services. We can actually increase our price to $41.50, right? Okay, so now we're not at 42, we're at $41.50. When we come over here, we're actually making an extra $30,000 just because, but we're still underpricing the other laboratory. Okay, why is that important? Because you have total control of what you're doing, right? Because you know all your costs, because you know everything that you're doing, you have total control over what's happening, and so you can make that happen. So let's look at a government lab very briefly. So we're going to set that at 0. We're going to set this at 0. We're going to set this to be equal to our price just for a moment. Okay, so now what we're saying in this laboratory, this is a government lab where we don't say there are free patients because no one's paying, right? So no one's paying us anything. All the money is coming from the government. So we don't have a margin. So when we come over to our expenses and revenue summary, what we can do is say, okay, our revenue is $366,580. Our cost is $366,580. The government needs to give us $366,580, right? That's what our budget needs to be from the government for us to run that lab. So when we come back over here, look at that. Now our funding required per specimen is 0. So we know we've balanced our budget, right? Because we've done everything we need to do. So you can actually balance your budget just like you need to do, and you would put this at 0. And then what's going to happen over here is that this all is now balanced out. We've got our revenue equals our costs. The government's writing us a check for that to run the lab each year. We don't have any excess revenue, et cetera. We're all good. And the beautiful part about this is, let's say this is where we are on day 1, and we find out we're going to get a grant. Okay, that there's going to be another grant of another $100,000. So we're going to change this to another $100,000. And we come over here. Nothing changes over here, right? This is going to give us minus $10. Basically, that's telling us that we can reduce our government budget. So we can come back and say, oh, the government doesn't need to give us $466. They only need to give us $266 plus our $100,000. And now we've balanced our budget again back to 0. Okay. So this is a very useful tool for balancing your budget, figuring out what your lab costs, et cetera, et cetera. Now let's look at some of these calculated numbers, because this is very, very important. Grossing staff, histology staff, pathology staff, administrative staff. Where is that coming from? That's coming from this page. This is the assumptions and miscellaneous page. Now these numbers are the assumptions that are in the model, okay? And you need to understand these assumptions and adjust them for your laboratory. So the first assumption is the grossing staff rate. We're saying that the grossing staff, a single grossing staff, one person, can cut in 200 blocks in a day, meaning that could be, if you divide by 3, that's about 60 cases. So if 60 cases came in, they could cut those in a day. But we're saying our histology staff, each of our one histology laboratory employees can only cut about 100 blocks per day on the microtome. Okay, now in a US laboratory that's high volume with a really, really good histotech, they can cut about 250 blocks per day. If your lab isn't very busy and you don't have high volume, maybe you're only cutting 20 blocks a day, 30 blocks a day, but there should be a rate that you could accomplish, you could cut in a day, and that's what you have to figure out. And this is not something, this assumption may be wrong for your lab. It may be too high, it may be too low, but you have to start with an assumption somewhere. And then we have our pathology staff rate. This is the number of cases that pathologists would sign out in a day. This is set at a little low for 25 because if you're by yourself in a laboratory, or there's only one or two of you in a laboratory, it's really difficult, right? It's hard to sign out cases. It takes you longer. But in a high performance laboratory where someone is only doing prostate biopsies, they may be able to sign out 75 or 100 prostate biopsies in a day. So you have to look at your service and set it up that way. Then there's the administrative staff. How many cases can they type up their reports and process them and send them out for billing or send them out to clinicians? Again, we've put that at $50. Now, let's go back to the main sheet and understand what that does. So what that does is generates the number of staff that you need based on your volume, right? So according to this model, for 10,000 biopsies, remember we're at 10,000, we need 1 grossing staff, we need 2 histotechs, we need 2 pathologists, and we need 1 administrative staff. And we've now said this is how much they cost, and so we've projected our salary budget, okay? Very helpful, right, to be able to do it that way. But here's the key. You have 2 pathology staff, but are you using them too much, too little? You can actually come over here to assumptions and miscellaneous and scroll down to the bottom, and you get the actual FTEs based on the model. So we said you need 1 grossing staff, but in fact, the volume that your lab is doing only needs 60% of a grossing staff, but you can't hire 60% of a person, right? That's very difficult to do. So you either need to hire that person completely and that they have to pay for 1 FTE, or you are going to contract with people to cover your service and only pay them for what you need. So that's up to your lab of how you do that. And many labs in the US will contract out for the fractional margins that they need to cover their services in order not to waste any money. Look at the histology staff. We only need 1.3 FTEs to cover the volume based on our assumptions. So we're spending another 0.7 to have that extra person that's costing us out of pocket. Same for pathology, same for admin. So this laboratory currently has excessive staffing costs of about $30,000 that they're paying for, but they're not getting any additional work out of them. And so if you were in the US, for example, you'd say, all right, I'm going to hire 1 pathologist, but I'm going to get 2 other pathologists to give me 30% of their time, and then I will have enough to cover my services, right? So that's a way you can save that excess cost. All right, let's look at antibody costs, IHC costs. So what is this? This is from actual data. This is one of the only things in the model that's come from actual business data. The others all come from websites and that sort of stuff, but this comes from invoices for immunohistochemistry. And although these numbers are, I would say low, they're slightly lower than what you probably would pay today, they're still helpful for the purposes of the model. So the antibody cost average per case, what does that mean? So how many immunohistochemistry do you do on a given case? You could do 2, you could do 4, you could do 8, right? How much do you pay per antibody? Well, you don't buy individual antibodies. You buy a vial of antibodies, and then that vial of antibodies is divided over a large number of patients. So when you take what you pay for antibodies, how many tests you get out of that, and you divide it by the number, the total number of tests, and then the average number of immunohistochemistries for a patient, you can come up with an antibody cost per case of about $25. And for some antibodies, that may only be $5 for the antibody. For other antibodies, it might be $20 for the antibody. And then there are other costs for IHC like buffers and that sort of stuff, which is about $11.50 per case. So this $36.50 average per case is the assumption we're using. But you can do the math in your own lab, take your annual procurement, total number of potential stains that you can do, and divide that by the number of cases you're projecting, and that will give you the information you need to fill in there. So what does that end up doing over here? Well, because we've said 35% of our cases need immunohistochemistry, and we have 10,000 cases, that means 3,500 cases need immunohistochemistry. And so we multiply $3,500 times $25 and $3,500 times $1,150 to get these two numbers. Now, what I want you to look at is, and I'll show you this graphically, is this row of numbers. What are the largest numbers in this row? It's the cost of immunohistochemistry, okay? Now, is that problematic? Absolutely. It's totally problematic because immunohistochemistry reagents are manufactured primarily in the US and Europe, not manufactured in Africa. So when you buy antibodies for immunohistochemistry, you have to buy them from a foreign supplier, right? And that foreign supplier manufactured that antibody in a foreign economy, okay? So the GDP of the United States is such that production of antibodies is expensive, right? They have very expensive staff, very expensive insurance policies for those staffs, very expensive buildings, very expensive electricity. And so when they make an antibody, they have to charge a lot for it in order to make up their costs. Remember, I told you their margin is only 2% because of all these other costs. So, but you need to buy the antibody, but you're operating in a low GDP country. You need to have antibody pricing adjusted to what your economy is. And that's just not available right now. So immunohistochemistry is very expensive. So if we're in a US lab or an African lab, this number that we're paying for immunohistochemistry is very similar, and it makes it very, very challenging to do a budget. All right, let's go back over here. There's a couple of other assumptions here about number of blocks. So you have a formula, you have a processor in your laboratory, and you put formalin in it. How often do you change that formalin, right? Well, this sort of standard of practice is every 500 blocks. So when you run 500 blocks through that processor, you take all the formalin out and you put in fresh formalin. Now, you may actually not change your formalin every 3,000 blocks, every 4,000 blocks, every 200, whatever it is, but you have to look at your practice and say, how often do we change it? Do we just change our formalin every month with regardless of number of blocks, or do we change it every 500 blocks? So whatever that is, you can figure these numbers out, and you can change them in. Now, the interesting thing is if you recycle formalin, that's a special case, or recycle xylene or alcohol, this becomes kind of irrelevant, but you can adjust the model to account for that, and it saves you a lot of money. But this is just accounting for if we're going to use standard practice of changing every 500 blocks. This next section is very interesting. So we can't think of everything. The model is not perfect. There's every possibility of how laboratories are run. But what we've done is given you these tabs so that if you have some sort of embedding cost that we aren't accounting for, whatever it is, or slide staining cost, or IHC cost, or special stain, you take whatever that total cost is for so let's say, for example, for immunohistochemistry, I've given you $25 and $11.50, and you change those numbers up here to match your estimate, but there's still some other cost. Maybe you have to have a supply contract for someone to come in and do the maintenance on that piece of equipment separately, or whatever it is. You can just add that into this miscellaneous annual cost. And the way this model is done is that is distributed again as it needs to be across all of the cases that come in, okay? Then if you happen to be in a situation where you have a tax rate, you have short-term liabilities, long-term liabilities, interest rate on a long-term debt, those are all business terms, then this allows you to add them in so that this model will work everywhere. So let's come back over here very briefly and look at this again. Okay, so now what I want to show you, let's say we're doing 10% of our patients don't pay. And let's say we're a private lab with a 5% margin. And let's say we don't have any external funding. All right, so we're back to our private lab, and we're going to charge $42.77 because that's our margin, right? So here we go. This is our lab. This is where we are. All the parameters are set. Now, what happens if our lab volume isn't 10,000? Let's say that we projected, but our lab volume is only 5,000. Right? So what happens? So now we have to charge $51.43. And notice we said 43. So we have to charge almost $9 more per sample to make that up. Okay, so I want you to keep that in your head. So we went from 43 to 51. But let's say our volume is actually 2,500. Okay, hold on, sorry. Let's say our volume is actually 2,500. Right, not 5,500. Look how much our price went up. We now have double the price, right? So the price has doubled, even though our volume has gone down 75%. The price has doubled. That's a lot more that we need to bring in, okay? And our revenue, if we come over here to expenses and revenue, our total revenue, our costs, you know, they're much lower, but the cost per sample is much higher, right? So this is the economy of scale that we're talking about. So we set this lab, let's say this is your lab today. Everything is all set, the costs are set, et cetera. And this is what you'd have to bring in is $81. But if you just increase your volume to 5,000, right, by marketing or recruiting, whatever, now it drops, enter, there we go. Now it drops down to 50. It's more reasonable. If we did 10,000, right, it's back down to the number we had. What if we go higher? What if we went to 20,000? Now it's only $39. It's very close to $42. So this is that economy of scale. This plateaus eventually, and I'm going to show you that in just a second in a graphical model. This plateaus. And so where we need to move a laboratory, any laboratory, is to that plateau point on the curve. And given the pricing structure that we have in this, as we've had it set up, that model works out to about 12,500. But even when we look at, say, a US laboratory where the pricing is very different, it's still about 12,500. So what that means is that for any laboratory, anatomic pathology laboratory, that's doing less than 12,500 samples per year, you need more revenue per sample to do it because you haven't achieved the economy of scale yet for your system. So I just want to show you 3 other quick things. So this model will automatically give you a reagent and supply by process. So you can check for missing items times 1 year. So it tells you what you need for each process. And it will also give you an inventory order sheet to say, this is what you need to pay for and order for this particular year. I'm not sure why that says that number. Oh, because we went up to 12,500, yeah. And then the last thing is, so the last 2 things, you have an income and balance sheet, so you can actually see, you know, you can use a standard income and balance sheet, and then it gives you these graphical outputs. Now, this is really important. In this graphical output, on the left is the total breakdown. So you've got your overhead, which we set an overhead for this one. You've got the salary for our staff. We have our reagents and supplies, right? So our salary is about 36% of our budget here. Our reagents and supplies, it's entirely immunohistochemistry, right? 77% of our budget is immunohistochemistry. And remember, that's for only 3,500 of our 10,000 patients. So this is why subsidizing immunohistochemistry is so important. And this is the last point I want to make before we go back to the process. When we look at this $39 that we're asking for each sample, that's distributing the cost of immunohistochemistry across all patients, right? So we're not going to charge somebody that has HER2 an extra amount. We're just charging everybody $39, right? And maybe they're, the government's paying for part of it or whatever. Anyway, the point is we only need to collect a certain amount for every case, and we can pay for our immunohistochemistry. And this makes your budget very simple. People come in, they pay one price, they get whatever services they need, and the immunohistochemistry is subsidized across all of your patients. Now, is that fair? Does that make sense? Et cetera. You can do that however you want to do it. But if you look at it from the point of view of, let's go to this back to 10,000. Okay, so in this model with 10,000, we have 87,500, 40,250. Okay, so if we take those 2 numbers and add them together, you can do this on your own if you want to. 87,500 plus 40,250, right? And remember, we said this is going to be for 3,500 patients. Okay, if we divide that by 3,500, if we if we wanted to make patients pay for their immunohistochemistry in this model, we'd say, okay, you have to pay whatever the fee is plus an extra $36.50, right? And that's going to cover our costs. But in the model that we have everyone paying only slightly more, and it gives us the what do you call it? Offsets the cross subsidization so that everyone gets the same services. So it's not that it's a huge burden to them, but people will add, that's the cost. So people will add a larger volume to it. And there's the problem of trying to charge people separately for immunohistochemistry and figure it out. It's much easier just to say everyone's going to pay the same price and we will subsidize our immunohistochemistry over time. Okay. All right. So let me stop sharing this and go back to the presentation so that I can show you. Oh, 1 second. Hold on. I messed up. There it is. Okay. Okay. So now I showed you all of this. This is great. So let me show you some data. Okay. So this first model is showing you what happens if you have increasing number of pro bono patients. Okay. So on the left is the dollar cost, that revenue, that yellow box, right? That revenue per sample that you need for each sample to come in. And on the bottom is number of samples that come into the laboratory. So notice how between 8,000 and 12,000, the curve is getting flatter, right? It's not completely flat, but it's getting flatter, okay? And that's that economy of scale. As we go from very few samples to around 10,000 samples, the price drops precipitously, or the revenue drops precipitously per sample that we need to bring in. But notice in this series, we're doing there are no pro bono patients, or there are 5% of patients aren't paying, 10% of patients aren't paying, 15% or 25% aren't paying. And look at the plateau level, the difference between everyone pays and up to a quarter of people don't pay. The difference is only about $10, okay? $10 to $15. So we can actually have everyone that comes in to the lab in this 25% series, we can have everyone that comes in pay around $70 for their histology, and we can have up to 25% of our total patient population come in that doesn't need to pay. So we can offset the cost of those free patients by having a slightly higher price for those that can pay. Now, how you decide who pays and who doesn't pay and that sort of stuff is a different issue, but the take-home point is that this the pro bono aspect of the service does not have a huge impact on the budget. You can absorb quite a few free patients and still be able to do that. Now, this is just a standard lab. If we had a private lab that was for profit, they can actually still do this and not only have revenue, but accommodate government patients and subsidize. Now, I want you to notice these two blips because they're going to keep coming up in every graph. The first blip you can see is happening right here, and the second blip is here. And what are those blips? That's where our model flips from 1 FTE to 2 FTEs for the grossing or histology staff based on those assumptions. And then the other blip is where it switches to an additional pathology staff. Now, if you have 12,000 samples, or sorry, 12,500 samples, and you go to 12,501 samples, suddenly you need a new pathologist based on the model. That's probably not going to happen. You're probably going to hire that pathologist sooner than that, but the model is accounting for it as stepwise FTEs. But there is a way to look at this from a more smooth model. And what you have instead of these abrupt changes are sort of bumps that then flatten out again. So the price goes up a little bit as we hire a new person, and then it goes back down again as we plateau again. But keep this in mind as we look at these other graphs. So this is a mother series. This is the effect of external funds, right? And we already talked about if you're a government lab, you have external funds. So you can see that if you have no external funds in this model, you have that exact same graph we just saw on the last slide. But if you have 400,000 or 300,000 or 200,000 or 100,000, that offsets the cost and creates this very low threshold of payment that has to come in from patients, right? So if you have a government operating budget of 200,000, that's the green line, you're going to charge patients only maybe $10 or $15, and you're going to be able to pay for all of your services. But the key is you can make it affordable for them by accounting for your government operating budget. And notice that, again, those blips still occur, as we saw before, but they're not as dramatic because you have the external funding coming in to do that. Now, this is interesting. This is actual data, and we have 2 Nigerian laboratories represented in this data. We also have a Brazilian laboratory, 2 Ethiopian laboratories, 3 Rwandan laboratories, and a US laboratory. And there's 2 things I want you to note about this, okay? And the first is that all of the African countries, Nigeria, Ethiopia, and Rwanda, the curves are almost identical, right? And that's because the main differences in the labs was the price or the salary of the pathologists and the staffing. So the reagents and supplies were all very similar in cost, variable, but very similar in cost. The Brazilian lab is a little bit more expensive. That makes sense. The Brazilian lab is operating in a slightly higher GDP bracket than most of the African laboratories. So we would kind of expect that. But look at this Rwanda lab and this US lab. How could we explain that? What does that mean? How does that make any sense? The interesting thing about that lab, it's all Rwanda, the orange Rwandan lab is all Rwandan staff, right? So the staff costs are African, but they buy all of their reagents from the US and ship them over, right? This is just a historical way that they've run that laboratory. They don't buy them locally, right? And it's because it's run through an NGO. So you see what's really interesting is that and then the green line is a US lab. What's really interesting is when you get to this plateau between 8 and 10,000 samples, the African lab and the US lab become very similar. And it's because all of the cost at that point is the reagents. They've distributed the cost of the pathologist over all the patients. So the cost per pathologist the pathology is very cheap per person at this point, right? But the cost of reagents is really the challenge at that point. But then notice the big difference is when the US lab has to have a new pathologist, suddenly that price goes up enormously because of the cost of the pathologist. Okay, so this is a really cool graph to show this effect of reagents versus salary. And then this is the last slide I want to show you. So these are the salaries are on the left. So this is times 1,000. So the range of salaries, and this does not include any US lab. These are only the African and Brazilian labs. So you can see the range of salary for the pathologist is from low to pretty high, but for the grossing techs, the histotechs, and admin assistants, they're pretty much the same, right? So pathology salary is a huge driver here. It's a big difference. Now, then we look at some consumables, cassettes, gloves, and glass slides. Huge range in price. Some countries pay a ton more than others. Others pay very little. So this is a place we can work on. This is what we need to figure out. How do we get this pricing to be relatively similar so that people are not paying disproportionate pricing? And then we can see things like microtomy blades, and then formalin per liter is variable. Formalin's pretty cheap. Alcohol is most expensive, and therefore it has more variation there. So again, this is just showing you the difference between what different labs pay across these 8 laboratories that we looked at. So let me summarize by saying that budgeting for a pathology laboratory requires that you understand your source of revenue and budget cycle time, that you have projections of volume for the next year, including growth, especially if you're going to increase growth through marketing. Understanding and transparency around pricing of reagents and supplies, how much do things cost is very important. Feasible expectations of existing staff. How much can your pathologist sign out? How many blocks can your histotech cut? You need to know that and think about that. It's both a measure of quality as well as helps you with your budget. And then transparency and fluidity in the movement of revenue supporting the lab. And this is the hardest thing for me to say because I know many of you don't have that depending on the type of lab that you're in, but you need to know how much revenue is coming into your lab versus your costs and have that be part of the same budgeting process to be successful. As long as that is disconnected, it will always be a challenge to try to run your laboratory. Different reagents and supplies have different use life, shelf life per use case, and must be considered specifically in budget. You can't just buy the same number of cassettes as you buy of slides, right? You need to think about your budget, the complexity of your budget, and predict how much you need. And working through a budget process for your own laboratory will reveal special considerations that may not apply to all laboratories. You may discover that the way that we've set up this formula, it's not quite right. It's not the right setup, and you have to do something different to do that. So each lab is different. So with that, I'm going to conclude. Let me stop sharing. And I think we will take any questions that you have in the minutes that remain. Any questions? Okay. So it doesn't look like we have any questions. So this is being recorded. I think I'm just trying to see. We didn't have a ton of participants today, but hopefully you'll be able to listen to the recording. The paper has been submitted for publication and hopefully will be out soon. And we're happy to work with you about it. We do have a question from Joseph. Majorly in Nigeria, patients are billed flat rates. I wonder if the model can accommodate that. Yes. So this model, Joseph, you can set the price, right? I showed you on the box. You can set what you're billing people. But does that mean that you are actually making any money or meeting needs? So let me pull this up just so I can make sure that I'm not confusing you. Okay, so let me go back over here. I'm sorry, 2 seconds. Sorry. Okay, share screen. Here we go. Okay, Joseph, here is oh, from Maxie. No worries, Joseph. Okay, so Joseph, Maxie, so if we look right here, we see this thing called list price of specimen. So let's say the flat rate that we charge our patients in Nigeria is $50. Okay, let's just put $50 here. Okay. So that's what we're charging our patients. And let's say everything else is right in our budget, except that our lab only sees 3,600 patients per year. We only have 3,600 patients coming in. Okay. So that $50, what I'm showing you is and let's say you don't have a margin because it's a government lab. That $50 is not, and let's say everybody pays, right? Because everybody's going to pay. So we're going to set this to 0. Okay, so now everybody's paying. We don't have a margin, so we have pretty much the parameters right, and we're only doing 3,600 per year. We need $54.10 per sample, but we're only bringing in 50. So that flat fee isn't going to cover it, right? So we either have to raise our flat fee or we have to do something else, to do that. And so this is how the model can help you. If you've got a flat fee, you just put that in here, and then you put in all your parameters, and it'll show you the difference. And what you see over here is that you've got a $14,000 deficit in your budget, right? If let's say the opposite though is the case. Let's say you're charging a flat fee of $75. Now you should have this excess revenue of $75,000 is coming in. Where is that money going? Is it being reinvested in the lab? Is it allowing you to expand services, et cetera, et cetera? So you can definitely use a flat fee. That's where you would put it. And then you can look in that. And yes, it is possible to share the template. What we would love to do is if individual labs want to work with the template, we'd like to work with you on it directly, because the paper isn't published yet. So if we work with you on it collaboratively, we can make sure that you're using it correctly, get any questions answered, make sure that it's not malfunctioning or working properly, and then help you use it that way. We could just share the link, but I think it's a very complicated model, and it's best to work through it with somebody. And what we're going to do is when the manuscript is accepted for publication, We're going to record YouTube video how-tos for each of these sections so that people know exactly how to use the sheet. And then we'll be happy to share it with anybody who wants to use it on their own, because the videos will be out there to do it. So until we have those videos, I'm happy to work with people on it individually, for sure. Any other questions? All right, well, thank you guys so much. As I said at the beginning, hopefully you heard it. Gloria will send out an email. This Thursday, our speaker was unavailable, so he is moved to the 20th of June. And so there will be no session this Thursday, but we will resume next Tuesday. So I apologize for that. If you've already registered, don't worry, we will capture your answers, but you'll have to re-register for June 20th. But we do hope to see you all next Tuesday. And again, apologies for the change to the schedule. Thanks everybody so much, and talk to you soon. Bye-bye.